he was 46, 43, something like that. This is an April study, and he came in with flank pain or something like that. And this was read, and this was read as a, you know, thickening at the G junction,
The
you know,
hard call.
correlate for symptoms of gastritis.
For
Um,
for
say
me,
again?
the stomach is too thick as you work your way through the antrum and pylorus.
Right. So here
Because the
I'll
proximal stomach I've seen look like that, but then as you sort of follow it round to the antrum and pylorus, it stays that thick all the way.
Okay. Okay, so I'm going to read you what the actual statement was. Apparent thickening of gastric fundus, at least in part related to non-distension. Clinical correlation for symptoms of gastritis is recommended, and the guy is 43 years old, came in with right flank pain. So this is how this was read, and the patient went on their merry way and came back last week or so. And again, he's 43, and um, his now indication was abdominal pain, roulotte cholecystitis. He's 43,
Ooh, now it's
right?
like more obvious, but
So now
Yeah,
there's
now it looks
like
like a mass.
yeah, so it looks like a huge distal esophageal mass with look, there's lymphadenopathy there. There's lymphadenopathy. Just go past it like here. So we're still waiting for the path, but they saw like an ulcerated mass on endoscopy. So, and the patient, like, once they realized this, that they did elicit some history of dysphagia and thought. So there was something real here. You can see
What's the time difference between cases?
this was in April and this is October. So
Okay.
yeah,
wait, so
April 10th to October 29th.
I often find that we overcall like
Oh,
stomach.
absolutely,
pain.
absolutely.
So when do you guys like for that the first? I don't know that I would have had the confidence to make a prospective call.
Right. So, so that's why the thing was, So this is something that my former mentor and boss taught me. She uses the wording apparent thickening because it appears to be thickened. So apparent thickening.
Mhm.
So I often say that apparent thickening, and in this case, I said at least in part related to suboptimal distension or non-distension, which I say that occasionally, and in vast majority of cases, it's just collapsed stomach.
Mhm.
But in this case, it happens to be not that. And then yeah.
Victor, like, or Steve, like, do you guys recommend anything in these cases?
This is subjective and experience-based type
Absolutely.
calls in radiology.
Yeah.
And so on any given day, had I encountered that, would I have said something? I think I probably would have. I might not have been totally on the mark, and I might have been digging in the chart trying to find out if they ever had a upper endoscopy within the last couple of years. But I think I probably would have said something. I mean, here we are in a case conference where you don't know, people are showing you stuff that obviously turns out to be something. And it's hard to know exactly what you do prospectively. The case reminds me a little bit of a case that it's kind of unfortunate. There was a severe gastritis that was so thick on CT. Even when we tried to distend the lumen, the wall was incredibly thick, and the guy ended up having a gastrectomy because the surgeons were convinced it was linitis, and they just basically took it out, and it turned out to be all just inflammatory cells and no cancer in the stomach. So I maybe if I can dig up that case, I can show you sometime. But the stomach's pretty hard. There's at least one article out there with Perry Pickert saying that we have a tendency to overcall thickening around the pyloric channel, as in the early days of CT, as being suspicious, and all these patients going for unnecessary endoscopy, and 99.9% of them turning out to be nothing. So it's easy to overcall.
This is why
Right.
I
No,
want all my patients to drink like water the minute they get on the gantry. Just chug
so,
a cup of water, you know? It like
yeah.
clarifies the
Yeah.
stomach so much more than
Water is a good distending
Mm.
agent.
So
Yeah.
I agree. We about overcold. So unless I'm like really concerned, I don't recommend endoscopy. But I usually say just correlate with symptoms. I guess I think that here they could have talked to the patient and seen, you know, and maybe they would have elicited early symptoms of dysphagia. But who
Yeah.
knows?
So sometimes if there's a good doctor on the end of a soft call, a diagnosis gets made sooner.
yeah.
Right.
Like right now at my institution, we stopped giving oral contrast for all patients coming through the ED, urgent care, like except for very specific cases. But like, I mean, it's exactly these cases where I'm like, oh God,
Right.
oh, if they don't just have a little bit of water, you know. Anyhow,
Right.